Good morning, everyone. Thank you all very much for being here. It's a great pleasure. I'm Jin Dong. I'm an associate professor at Columbia Business School. So today I would like to talk a little bit about my research, which mainly concerns from predictive analytics to prescriptive analytics in healthcare. In particular, I will give two examples of my recent projects about how I actually bridge in the two. So my research interests are mostly in healthcare operations management, with a special focus on hospital-related care. Well, as we all know, healthcare spending in the US is the highest in the world, with hospital-related expenditure taking the lion's share of the national health expenditure. So this basically indicates that even if we can make modest improvement in the healthcare operations domain, then this could actually lead to substantial economic impact. Now, meanwhile, as we have probably experienced firsthand, hospitals in the US are often rife with inefficiency. We experience frequent congestions and significant delays. So these inefficiency and congestion can affect patient outcomes and satisfaction. So there are actually a lot of rooms for improvement and opportunities for us to make an impact. So the other thing that motivates my study is that in recent years, we've seen a growing number of predictive models being developed in the healthcare domain. And these are mostly driven by three factors. First of all, with the wide adoption of the electronic health record system and also the advancement of monitoring devices, we simply have more data available nowadays for us to build these models in the first place. And second, the advancement of statistical learning and machine learning methods has provided us with a broad tool set to achieve high accuracy models. And lastly, there's also improvement in hardware. So basically, we simply have more computational power now to do data storage, processing, and optimization. Now, we've seen these growing number of predictive models, but I guess from the operations perspective or from the business perspective, what we truly care about is how these newly available predictive information can help us make better decisions. So this is what I mean by from predictive analytics to prescriptive analytics. And for today's talk, I will give you two examples of how we were able to bridge the two. So let me start with my first example. So this is about proactive ICU care. ICU here stands for the intensive care unit, which is the unit that is providing the most critical care in the hospital. So it has long been identified in the literature that acute deterioration of hospitalized patients outside the ICU is associated with high mortality and morbidity. Meanwhile, indicators such as changes in a patient's vital signs or oxygenation often precedes these clinical deterioration. So this actually provides an opportunity for us to detect these potential deteriorations earlier and provide proactive treatment to improve patient outcomes. Now, for this first example, I would like to discuss the key considerations when we think about utilizing proactive care to improve patient outcomes and hospital efficiency with the newly developed early warning systems. The first thing we have to think about when implementing these proactive care is that hospital is a limited resource environment with high uncertainty and variability in patient demands. Thinking about reaching out to the potential risky patients earlier could mean that fewer resources are needed to help them and stabilize their condition. Meanwhile, if we are providing resources and care to these potentially risky patients, we might take the critical resource away from the more severe patients. So in this context, we have to think about when and how to provide proactive care or to prioritize this proactive care should it depends on the overall system congestion level and the resource constraints. In most hospitals, the proactive ICU care is provided by a team called the Rapid Response Team. However, who should be on the rapid response team, when should we trigger the rapid response team, and how the rapid response team should react to different situations varies a lot across different hospitals. So these leads to actually vastly different outcomes and performances across hospitals. So in this work, our goal is to incorporate the predictive early warning systems to develop a good prioritization policy for proactive care, essentially when we should actually trigger the rapid response team to react to these potentially risky patients. And we fully take into account the resource constraint and the system congestion level. So when things should be triggered is actually state dependent. It depends on how many beds we have available, how many more risky patients we have in the system, etc. Now, let me go on to the second consideration. So we all know that these predictive models are not perfect. So we could actually make mistakes when doing these predictions. Therefore, when to provide proactive care and who to provide proactive care to should also depend on the accuracy of this prediction model. So we've seen that because the idea of missing a potentially risky case sounds so bad, so the hospitals often put this early warning system at a pretty low triggering threshold, which basically means that a lot of the alarms these early warning system triggered are actually false alarms. This has led to huge alarm fatigue problem in the hospital in recent years. Basically, the nurses stop responding to these alarms because they know that a lot of these alarms are false alarms. The other issue with this early warning system is the interpretability. So most of these early warning systems just output a single score. So how to interpret these score and how to translate this score to concrete treatment plans requires further educated interpretation. And the ability of the rapid response team to interpret and come up with actionable strategies based on these early warning scores also varies a lot across different hospitals. So the other thing we are trying to address here is to take the accuracy of the prediction model and the interpretability of the prediction model into account when we design the good proactive care strategies. Now, without going into the details of the exact policy we're able to develop, let me just say that by combining the mathematical model with predictive analytics, we are able to develop a proactive scheduling. We are able to develop an optimal scheduling policy for proactive care in this intensive care unit setting. So I'm showing two plots here. The first plot basically demonstrate how we address the first points. So basically, the actual proactive care policy depends on the congestion level of the system. So it depends on how many patients from each class are waiting and how many beds we have available to take care of, how many resources we have available to take care of these patients. And the second plot here demonstrate my second point. So what our proactive scheduling policy depends on how good our early warning system is. So here, the arrow here shows that as the early warning system become less and less accurate, we are being less and less aggressive to do the proactive care. So the nice thing about having these results here is that we're able to quantify exactly how these two factors is going to affect our optimal scheduling policy. And then we're able to provide hospitals with concrete actionable policies that builds on this predictive analytics. Now, this is the first example I would like to talk about today. And let me move on to my second example. So the second example is emergency department surge planning. So the question we would like to look into here is that first, can we use real-time information to develop better prediction models for ED demand? And second, how can we incorporate the predictive ED demand to actual ED staffing decisions? So the first part is about developing the predictive analytics, and the second part is about how to develop actionable policies based on these predictive analytics. Now, let me give a brief overview of the key considerations when thinking about ED staffing decisions. So in most hospitals, the emergency department nurse staffing is done at 2 stages, which we are going to refer to as the base stage and the surge stage. Let's think about a nursing shift that is going to happen, let's say this morning. Then the base staffing, in terms of how many nurses should be working in today's morning shifts, is actually determined weeks or even months in advance. So this is the most standard staffing practice in the hospital. This would give the nurses actually let the nurses know their schedule ahead of time so they can plan other things around this schedule. And nurses who are scheduled at this base stage are paid at a base salary. And the obvious disadvantage of doing the most of the staffing at this way ahead of time is that when we are a few weeks or months away from today's shifts, we are facing a lot of uncertainty about how many patients is actually going to show up today, what is going to be the risk profile or the severity profile of the patients that is going to show up today. Is it going to be a bad flu season or a good flu season, etc. Now, the hospital do have an opportunity to adjust the base staffing level as we are getting closer to the start of the shifts. So that is what I marked as the surge staffing epoch here. So the surge staffing could happen just hours before the start of the actual shifts. Because the nurses are called in very last minute, so in order to compensate them for that, we have to pay them at a higher rate, which we refer to as the surge salary. The current practice is that the surge salary is in general 1.5 to 2 times the level of the base stage salary. And the obvious advantage is that as we're getting closer to the actual shifts, we have more information about what is going on in the ED, so we are facing a lower level of uncertainty about the demand in our ED. Now, in order to embed predictive analytics into the ED surge staffing decision-making, the first task we're going to do is to actually develop a 2-stage prediction model. And the 2-stage are fully synchronized with the decision epoch for these staffing decisions. In particular, we're going to build a prediction model when we are making the base stage staffing decision, and then another prediction model when we are making the surge stage staffing decision. So in terms of the prediction model, at the base stage, we only have very basic information available. So we can capture the day versus night effect. We can capture that different day of the week might see different demands. We can also capture the months of the year effect, whether it's a flu season or not, and the basic holiday information. Right? So these are very basic information we have available at the base stage. While at the surge stage, because of the electronic record system we have, we actually know a lot of information about what is currently going on in our ED. We have patient count information of patients who are currently in our ED. We have their severity profile, things like their comorbidity scores, reasons for their visit, their lab orders, discharge destinations, etc. In addition to information available inside the hospital, we also have other information like the weather and also the Google Trend data. How many people are searching for keywords like flu, depression, heart attack, etc. Now, based on different amount of information available at different decision epochs, we are able to develop a 2-stage prediction model. And here are the performance of our prediction model for 2 different hospitals. So one is a hospital in New York City and the other is a hospital in New Jersey. Now at the base stage, let's look at these, which can be interpreted as the error rate of our prediction model. So in this case, compare the base stage to the surge stage. The surge stage is able to improve the error rate from around 9% in the first hospital to 8.8%. And for the second hospital, we're able to improve the error rate from 17.7% to 9%. Now, if I present these results to my colleagues who work in machine learning or statistical learning, they would say that these improvement in accuracy actually doesn't look very impressive. Right? If you judge the absolute improvement in the error rate here, especially for the first hospital, it's actually a fairly small amount. But the key question we are interested in here is how these improved accuracy is able to help us improve our operational decisions, in particular nurse staffing decisions in this particular case. So by incorporating these predictive information into the staffing decision, we are able to develop a two-stage staffing policy. So here, N1 denotes our decision at the base stage staffing, and N2 denote our decision at the surge stage staffing. And lambda here is basically our predicted demand at the base stage. So we see that at the base stage, the idea of the staffing policy is to match the predicted demand plus a hedging term, and this hedging term is mostly hedged against the demand uncertainty we're facing at the base stage. Now, at the surge stage, L is our predicted arrival or predicted demand at the surge stage. So the surge stage is essentially adding staff if needed to hedge against the system stochasticity, and which is basically this blue term here. So what this stochasticity means is that even if we have a relatively accurate prediction of ED demand, we still face a lot of variability in terms of the actual arrival time of these patients and how long the patients would require to stay in the system. Now, with our two-stage prediction model, we can actually measure how much cost improvement we're able to achieve, in particular with certain target performance metrics set by the hospital, such as having a waiting time that is less than 30 minutes, or having less than 2% of the patients left without being seen, or having more than having less than 20% of the patients who would wait for more than an hour, then we can see that our policy is able to achieve different amount of cost savings according to the current practice. Basically, across all these cases, we're able to achieve around 11 to 16% cost saving on an annual basis. And this translates to $2 to $3 million per year in our partner hospital. All right, so that's the second example I would like to talk about today. So in conclusion, I basically give you a few examples demonstrating how we actually are able to bridge from predictive models to actual prescriptive solutions. Thank you.
Thank you so much, Jing. Super interesting to see how policies that come into place, where they come from, and all the ideas and work that go into that. So thank you so much for sharing this with us.